For 5 minutes.
Thank you, Mr. Chairman. Appreciate that very much. Dr. Melton, we've been talking some about naloxone, and I know there are going to be folks watching this at home today and who'll be watching it at home over the next week or so as the C-SPAN replays it. Can you explain to the public what naloxone does in the case of a heroin or opioid overdose?
Sure. In simple terms, naloxone is an opioid antagonist or a blocker, and so when naloxone is administered either intranasally, IV, or intramuscularly, it goes to the receptors in the brain to block opioid receptors, and so it will kick off heroin, other opioids immediately, and by doing that, it reverses respiratory depression and other central nervous system depression that leads to death. So what happens is the patient goes into nearly immediate withdrawal. But unfortunately, naloxone only lasts for a short period of time, and so often additional dosing is needed, especially with methadone overdoses, which has a very long activity in the body.
So it's not to help somebody who's got a problem continue their problem, but it's to help them if they've had an overdose so that they don't die. Isn't that correct?
Absolutely right, and it should never be considered that people will use naloxone so that they can have a higher dose of heroin. You ask any addict if they want to go into immediate withdrawal, and they will tell you it's their worst nightmare.
Right. I recently led a bipartisan letter with 22 of my colleagues here in the House calling on the administration to develop practices for naloxone use and reprogram existing funds to provide naloxone to medical providers. I think that's a good idea. You have mentioned here in your earlier testimony Senator Kane's bill that provides Good Samaritans with some immunity from liability unless they're acting grossly negligently or maliciously. What else do you think that we can do to promote this from a congressional standpoint and make sure that the public is aware of it?
Well, I think one issue is I think we're getting the awareness going across the country now, but access to it, patients being able to afford it is a difficulty. It really needs to be mandated coverage by insurance companies so we are able to access it easily at the pharmacy. Virginia's new legislation will allow pharmacists to, through a collaborative practice agreement, write prescriptions for patients that come in and ask for it and train them on the spot, which I think is a huge step forward. So that will increase access. But again, the payment issues are a barrier.
And nobody's accusing the Virginia legislature of being soft on drugs or being liberal in this area. Wouldn't you agree?
I agree.
Yes, ma'am. Now, my district and our region of Southwest Virginia shares borders with 4 other states, West Virginia, Kentucky, Tennessee, and North Carolina, 2 of which are represented here today as well. This makes it easy for people to cross state lines to doctor shop and gather multiple prescriptions and from multiple pharmacies to get large amounts of prescription painkillers. What effect has this doctor shopping had on our problem, and how might we address it? And I'll start with you, Dr. Melton, but the folks from Tennessee and West Virginia are welcome to chime in.
Okay. So as I stated in my testimony, Virginia, Tennessee, West Virginia, and the other border states will soon be participating in the Interconnect, which allows prescription drug monitoring programs to connect across state lines. So when I have a patient that comes in, I automatically run a query. Let's say from Virginia, I can access 15 different states immediately and see if they've had any prescriptions filled in other states. It's been amazing to see how we're able to identify doctor shoppers and identify them as a potential for addiction and get them into treatment.
Yeah, and I would have to say, for those who don't know the area well, you can actually, you'd have to work at it, but you could actually hit all 5 states in a single day if you were really organized.
Yes.
Do either of the other folks want to add something?
Well, from North Carolina, you know, obviously we're along Virginia and Tennessee and so forth, and we have the same program to where prescribers then can access each individual state so that they can check the patient's history to make sure that they're not crossing those lines.
Very good. Dr. Max?
From West Virginia, yes, we have recently passed legislation for pharmaceutical tracking, etc. Just one point is that, you know, an unintended consequence from cracking down on the pill mills or whatever may be responsible for the increase in heroin use that we're seeing now, because the patients that are coming in are not on oxycodone or hydrocodone or Percocet or any of these drugs any longer, but they are on heroin, which is more easily available, and that might have been an unintended consequence.
Yes, sir. Appreciate it very much. See, my time is up. And Mr. Chairman, I thank you and yield back and thank all the witnesses for being here today.
Thank you, Mr. Griffith. We're going to take a brief break to have votes. We should be back.